Good afternoon, and welcome to today's HME News webcast. I'm Christina Thronson, publisher of HME News, and I'll be serving as your moderator. Like all of you, I'm real excited for today's session featuring Sandra Canally, RN, founder and CEO of the compliance team. Sandra will share real world examples and insight learned since the CMS DMEPOS accreditation changes, including where teams are getting tripped up, how to strengthen your day to day compliance, and what to keep an eye on as requirements continue to evolve. Now, I'd like to draw your attention real quick to the screen for a quick poll question. Give you one quick second here. There we go. Now, before we dive in, I do have a couple quick housekeeping notes. The session is going to be recorded and will be available for online viewing. Please go ahead and submit your questions at any time using the question button. I'll bring as many as possible to Sandra during the Q&A session following the presentation. So with that, Sandra, I'm going to let you go ahead and get things started.
Thanks so much. Looking forward to discussing all of this with you today. So our objectives for this is to talk about strategies to avoid common deficiencies, navigating the world of corrective action plans, and preparing for future changes. So this obviously is a joke, but you would be surprised as to all of a sudden providers are saying, oh, wait a minute. So it's changing from 3 year to 1 year. When did that happen? So we we made a joke because obviously they were living under a rock and now they know. But anyway, just thought it was cute. So the world we live in right now in the DME industry, as it relates to accreditation, is all about this slide. It's all about achieving mandatory 100% compliance. Now, what that means is no matter who you're accredited by, you have to meet every part of the standard. Now, typically, AOs have a standard and then they may have it, the compliance team, we call it evidence of compliance. So there may be 5 things under that standard that you need to meet in order to meet the standard. And that's what we're talking about when we refer to 100%. Now, if, for example, there are 5 things that need to be met and you only meet 3, that means that you're going to be doing a corrective action plan for those 2 items that you're not in compliance with. The whole issue with corrective action plans is it includes paperwork, it includes submissions back and forth between the AO and yourself. And last but not least, we have to send all of that to CMS. Now, the most common deficiencies that we've seen in this first quarter are licensure, meaning that they may not have the state license to operate. They may not have a license to do a specific product. Staffing during reported posted business hours. In other words, they're not open. Patient record reviews where they don't have enough files to show us. Equipment management, where equipment is just not being handled and stored correctly. They're lacking policies and they're lacking training. And typically, documentation is in there throughout. Now, I'm going to talk about 3 things that can generate either a denial, meaning that you don't have a PTAN, all right? So we're going to deny your accreditation, or terminations or revocations. Both words are used. You currently have a PTAN and accreditation, and we're going to revoke your accreditation. Again, state licensure is big. It's not current. The license is needed in order to provide products in that state. One of the other things where it's product specific is, okay, you need a bedding license and you do beds and you have been doing beds and servicing your clients with that. And now maybe your bedding license expired 5 months ago and you weren't paying attention. So we come in to do our survey and evaluate, look at all your licenses and realize your bedding license is expired. That would mean we would have to deny your ability to do beds until you updated that license. So these are areas that are serious that we then need to report to CMS with state licensure as it relates to the overall state. Business is not fully operational. This I can't stress enough. You need to be there. Someone needs to be at your operation during posted and reported business hours. Now, what I mean by reported is you need to report your hours to your AO as well as to CMS. So CMS looks at that. We show up, you're not there, no one is there. If you're having issues, and you're the owner and you have one employee, you need to make sure one or the other is there during business hours. There's no wiggle room here. That you have equipment, that you're stocked, that you're open during this time. And last but not least, accessibility requirements. Now, what does that mean? Typically, you might be in a gated community. Well, if it's not open to the public, meaning that your patient couldn't come in, CMS couldn't come in, we can't come in as your AO, then you're considered, obviously, deficient. All right. And we came across one provider, I think it was in New York City, where it wasn't just to get into their store where they had a keypad. It was a keypad that got into the building, and they were on the second floor of the building with no way of no doorbell, no nothing. So that's inaccessible. And this is so serious that we then have to turn around, not only deny your accreditation at that point in time, but we've got to report it to CMS. Now, the other way you can get denied or terminated is if CMS picked up the phone and said to whatever AO, so and so medical equipment company needs to be denied. All right, here's a little more with state licensure. This, even though it's a denial revocation alert, and we've talked about that, you should know what licenses are required. And you should be looking at, 6 months in advance, whatever, track your expiration dates. Look at, make sure you're looking at Novitas and Palmetto as it relates to what is required for each product you provide. This is key. you actually, as many things as you feel are out of your control, this is very much in your control for you to know when your license is expiring, and more importantly, what license you even need. There are many mail order companies now, and they send out products to multiple states. Well, then it becomes even a little more difficult because you've got to check out all of those states and make sure that you're meeting the criteria, because some states require brick and mortar. So you always, whether you're in business a year, 2 months, 10 years, whatever, you always want to make sure that you know what the requirements are as it relates to licensure. Now, again, during reported posted hours, you want to make sure that whatever the hours are, that it matches what you submitted. And if there are any changes to that, then you're going to have to report those changes. Have a plan B. If, for example, you as the owner can't get there till 10 and your posted hours are 9, then get your other employee to make sure that he or she are there at 9 o'clock. Certainly when we show up, we meaning any of the AOs, it's always unannounced. And therefore, you have no idea when we're coming. But you know the requirement for being there during posted hours. And the fact that, okay, if you're a new provider, you need to make sure your hours cover 30 hours per week. Another area that we're seeing a lot of deficiencies is in the patient record review. When we do the on-site survey, we look at patient files. First, we'll talk about you're a new provider, and we're going to ask to see 5 patient files. Now, you don't have Medicare yet. You don't have a PJAN number, right? So mainly we see cash as files to look at. You also need to have those files reflective of what you want to get accredited for. So if you're doing braces, if you're doing walkers and canes and crutches and things like that, you want to make sure that they're the items that you have files for, that you've sold them for cash. The other thing is you want to make sure that it's a Medicare covered item. A lot of times we go in and we see diapers or we see blood pressure cuffs. And that's, even though you sold it for cash, it's not a Medicare covered item. So we need to see a Medicare covered item. Now, a renewing provider shouldn't have difficulty. They must have 5 Medicare patient files. That's number one. And then if they do Medicaid, if they do Medicare Advantage, if, the Blues, whoever the other payer is on top of those 5 files, then we look at those as well. But you want to make sure that you're meeting your AO's requirements for the patient records. And this isn't even getting into what needs to be in the file, because obviously there are many items that need to be in that file. Now, if you currently have a Medicare number and we go for your renewal visit and you have 2 files, say, we're going to ask you, we're going to ask you anyway, to run an EOB report so we can see just how many folks on Medicare were actually billed. Now, if at the end of the survey, we're still unable to get those 5 Medicare files, then we've because you say, okay, I only serviced 2 Medicare patients in the past year or the past couple years, the rest is Medicaid. Then what the AO has to do is we have to go to CMS, and CMS will check and see if there was any other Medicare billing. And if there was not, they're going to come back to us and say, okay, compliance team, you can accept their 2 Medicare files and the rest Medicaid is fine. If they do the report and it shows that you had actually billed 20 or whatever, then clearly something isn't right. And somehow, some way, we've got to see the files that we need to see. Now, each AO might have an additional criteria for how many total files as a renewal that they ask for. All right, equipment management. You would think, I can understand new providers, but current providers that have been in the industry a long time need to know how to manage their equipment, how to track, how to document rental equipment from, buying it to, we're going to look at it from the point of buying it from, the manufacturer, from Pride or whoever, to who it went out to the patient and how many patients when like an equipment history record. Now, most of you utilize electronic tracking at this point. Nothing is crazier than going into a provider that has a lot of inventory but can't begin to identify where that equipment is or where it has been. You've got to be able to show that because number one, you've got to be following manufacturer guidelines. What we look for in managing the equipment and storing the equipment is designated areas, dirty and clean, testing, repair, patient ready. You should be always doing a walkthrough and checking out your storage area to see what is up to date, what needs to be changed, as well as the delivery vehicle. The other thing we're seeing are oxygen tanks where they're stored instead of being secured like they need to be in those containers, the cylinder containers. They're being stored willy-nilly on top of one another, full versus mixed with empty, just all sorts of combinations. No kind of analyzing of the oxygen, just all over the place with storage of oxygen. And, back in the day, even a few years ago, the providers that did oxygen, we would expect them, if they're doing oxygen, they know what to do and how to store it and so forth. And these days when we go out, there's issues. And again, you've got control of it. You know how to store the oxygen. All you need to do is look at the manufacturer's requirements with oxygen, with any other piece of equipment. The other thing I'd like to say is I always looked at equipment management as, if not the most important part of, because you're an equipment company, you're a DME. So when I used to go into, I would start the survey after the little tour and so forth. I would start in the warehouse or in the storage area, even if it was small, because it really told you what kind of day you were going to have. If the equipment wasn't stored correctly, there wasn't any kind of tracking, you you would know that that impacts the end delivery to the patient. So pay attention to your manufacturer guidelines. You should have all of that, whether or not you look at it online or whether you have it in a binder. But equipment management is key. Policies and procedures, we have our standards organized according to corporate compliance, administration, equipment management, patient services, infection control, HR, quality improvement, on and on. And probably the biggest error that we see is if you see policies that don't mimic day-to-day practices. They maybe they bought the manual and it's very nice, has very nicely written policies and procedures, but it doesn't match what they're actually doing. A good example is even if you're using templates or sample policies or just in general policies, and you come to a cleaning policy, and the cleaning policy says, okay, you use bleach and water and you use Meticide. Well, as an accreditor, you're not, that's going to be a deficiency because you're not, you say your policy is one thing and you're actually doing another. So it gets down into those details, and that actually is going to help you be a better company because you want your policies and procedures to reflect what you do and how you do it, because you have to train your employees. You obviously want to do right by your patients, and you want to make sure that all of your employees know what the policy says and where the policies are. Training is another area that we see deficiencies in, mainly because there's quite a few that need annual training, such as corporate compliance, HIPAA, OSHA. You know, with OSHA, you have OSHA's right to know that there's hazardous material in your workplace. You have bloodborne pathogens if you're doing something where you're exposed to blood or bodily fluids. You've got TB, if that's an issue. You've got emergency preparedness as well as fire safety. Those are things that just come off the top of my head in OSHA, as well as corporate compliance in HIPAA. So you've got quite a few things. You've got vast knowledge with tapping into the manufacturers or even OSHA's website for videos, for training material for you to utilize. You want to make sure that all this training is documented, that it can be in their personnel file, or it could be in a training manual, or it's documented online. And the training starts with the orientation upon hire and then annual leave thereafter. Certainly, if you add equipment, if you start doing a different type of service that you haven't done before, then you're going to be training your employees on that. And we're going to look for evidence of that. If you have any independent contractors that are doing deliveries for you, or anything, they could be doing computer work or whatever. We're going to look at independent contractor files the same way we would employees as far as training. So set your calendar reminders. Now, other new requirements that came with the final rule was change of majority ownership, change of location, relocation, excuse me, adding new locations. This all used to be very simple. And now with the final rule, it's gotten a little tricky. multi-site locations, adding new product type, and we'll go into more detail. And then, of course, complaints need to be reported to us and then to CMS. So we used to look at change of ownership, whether it was a stock or asset sale. Now it's more than 50% direct ownership would definitely mean a new survey. If this change is within 36 months of the Medicare enrollment effective date, you must also re-enroll in the Medicare program as a new DMEPOS provider. Now, keep in mind that we now have a moratorium, and that impacts that. Must be reported to CMS and AO within 30 days of the occurrence. Change, adding location, relocation. The provider is responsible for notifying their AO within 30 days of the move. And we must conduct another on-site survey at the new practice location. Now, if you're adding a new location, the provider is responsible for notifying us. We can no longer award a 90-day certificate like we used to. And the on-site only takes place once the new location is operational, unless it's a large chain, and then that's a different rule. And then the CMS 855S enrollment form cannot be submitted until after the successful on-site. Now, let's talk about chains. A chain is defined as 25 or more locations. So, one of the rules from CMS to the AOs is that we can do a sampling, but we must see that first 25. And then we do a percentage of the remainder per the AO's policy. And there's a difference between us. So you need to check with your AO if you are a large chain over 25 locations. The other thing is the CMS needs to approve our policy and methodology. Now, adding new product type, we'll call it type, category, however you want to phrase it, but a provider must notify their AO if they want to add a new type. If it's a different type / category than initially accredited, then an on-site survey may need to be performed. So my advice is, number one, plan ahead. We're going to be doing annual surveys. So because of that, if you're finished your say you expire the end of April. So from that point on, you're going to be seen annually by your accreditor. And so then plan ahead. All right, I want to add, maybe I did manual chairs and I want to add power chairs or whatever, especially if it's like one extreme to the other. Like we've had providers where they've done supplies, they've done maybe bracing, and then they want to get into respiratory. Well, number one, that truly is like a separate category. So we would absolutely have to do an on-site. So because of that, now if, say, for example, they were doing diabetic supplies and urologicals and they wanted to add trach supplies or whatever, well, then you're not mostly in need of another survey, and it's up to the AO whether they can just add it or maybe do a file review. Sometimes, okay, it's within a category, but it's a little different. So we want to make sure that you're knowledgeable and you know what to do. You have training with your employees, and we do what they call a file review. But certainly going from one category to another is going to generate an on-site. Now, remember we talked about 100% compliance. So now, all right, you didn't get 100%. Maybe you did very well and you only had a few things wrong, but you need to do what they call a CAP. It's a written document. We all probably have similar forms, but they're probably a little different within each AO. So the process is, no matter what the form looks like, you're going to get, and I'll just review in basic terms, you're going to get your scoring, and your scoring obviously points out that you have deficiencies. And then along with that, you're going to have instructions as to what you need to do with the CAP. And there are very strict timelines with different AOs. So at the end of the day, you need to make sure you understand what those timelines are with your AO. So after the on-site survey is complete, the surveyor sends in their information, and we'll use the compliance team, to our home office. It goes through our QA, and we then send out, as I said, the scoring and a CAP form. The provider then completes the CAP form and proof of corrections. And then it comes back into us, and maybe 3 out of 5 things are correct. We then have to go back to the provider and say, okay, you still need to send us proof of these 2 things. And by proof, let's talk about an example of training. So it's not, we're going to train on OSHA, bloodborne, but proof like this is the training. And we'll go into a little more detail, but it's all about sending corrections and proof to the AO. And then the AO approves it. If it's not approved, then it's returned, and they go back and forth. And then finally, we send everything, once it's received and approved by your AO, all of that needs to be sent to CMS. The survey, the scoring, the CAPs, the proof of correction. So we're getting a lot more reporting, as well as CMS, as well as the provider. If you don't understand the CAP process, you need to ask questions. You can't dilly-dally and take your time and think it's going to go away, because you're not going to get accredited. You're not going to get it done until you get through this process. Ideally would be to avoid it in the first place and be survey ready every day with 100%. Go through, if you have checklists from your AO, go through their standards, making sure that you check out your own organization to see if you're in compliance. And then, again, if you receive a CAP, and we already talked about that. Now, let's talk about the moratorium. So there are still new providers that are coming into getting accredited, or they did in that period where, okay, maybe they came in February, and come February 27th, CMS came out with a 6-month nationwide moratorium, which was a surprise to us all. And anybody that was in that mix waiting to get accredited, or they had not submitted their 855 with accreditation, came under this new moratorium. So they were no longer able to submit and apply for their Medicare number until the moratorium is over. Now, I'm an entrepreneur. I own the compliance team. So, as a business owner, I'm always looking for ways to diversify. If there's a barrier over here, then you go that way. And so now, for at least a few minutes, we're going to talk about a couple different things that you can do to go through a different door to revenue. Now, these two examples that I'm giving for alternative revenue paths typically require accreditation, but they don't require a PTAN number, which is why I'm highlighting this during this presentation. One is skilled nursing home contracts. Now, you're required to contract only with accredited DMEPOS providers. You invoice the nursing home directly and they pay the DME provider. So it's not about the individual patient, it's about billing the facility. The same with hospice. Again, it's similar to type of products to what you give into the nursing home, and they are required to contract only with accredited DMEPOS suppliers. Hospice covers 100% of DME costs. You invoice the hospice provider directly, and they pay the DME provider. So Medicare is not in the mix, which means the PTAN number is not in the mix. Now, what type of products are common in skilled nursing homes as well as hospice? You see a lot of, I know we have quite a few providers that even have PTAN numbers, but they've made a successful business out of servicing only facilities, and they specialize in enteral nutrition. So, doing things like feeding pumps and the actual food and all of the bags and tubes and specialized formula is a business right there. We had one provider that even has a dietitian because it's about nutritional support. Then you have providers that are doing mobility aids. So they're providing wheelchairs, walkers. They utilize staff training on the use and maintenance. And, that's part of their contract, as well as advanced equipment such as oxygen concentrators, CPAP, nebulizers, even defibrillators in certainly the nursing home population, and remote monitoring tools, which is very popular. Now, the keys to success: get your business in order. Look at those accreditation standards. It's not a one-person job. You need to document, update, keep current, and repeat. So when I say not a one-person job, we're talking about even if you have a staff of 3, you break down different things and give to your employees to check out in your business. Make sure you have the most up-to-date standards from your AO. And if they have some type of checklist, make sure you get it. Conduct your own mock on-site survey. And when you're deficient, start your own corrective action plan with deadlines and completion dates. Don't wait till the real thing happens. Try to prevent it. Make sure your policies are up to date. and that you've reviewed your policies annually. And again, I sound like a broken record. Make sure they reflect your business model. We talked about it not being a one-person job, getting everybody involved, assigning responsibility, and cross-training your staff. Conduct those weekly meetings with your staff during the transition period. Again, now that we're coming out every year, number one, it's going to enable you to stay compliant because you're going to be doing all of these things more regularly than perhaps you did before. And it's almost going to enable you to stay compliant. Oops, a daisy. I hit the wrong thing. Oh, good grief. All right. Da, da, da. Hold on. I don't know what happened. Hold on. Okay. I'm trying to find, I don't want to use slideshow. Okay, can we get that back? We were on a roll. Yeah. I just clicked the wrong thing. That's this next slide. You sure it isn't that? Use slideshow. Thank you. See, it's more than a one-person job. So sorry. All right, let me make sure. There we go. So document, update, keep current, and repeat. The new requirements creating more paperwork and documentation for all of us. We talked about that. Looking at your policies, your training, your HR records, and your patient surveys. Make sure you're doing patient surveys. Minimize the administrative burden by creating, a document management process, assigning responsibilities for that. And the secret to success, be survey ready every day. Look at this process as continuous. We look at accreditation and certainly our model at the compliance team as a measured continuous quality improvement program. That's really what accreditation is. It's not, okay, I need to do this today because the accreditor is coming soon. It's integrating all of these things into your day-to-day practice. And that's what's going to be your secret to success. All right, now I'm ready for questions.
Sandra, that was so wonderful. And I love it. Be 100% compliant ready every day. So good. So we've got a few questions, actually quite a few. So I'm going to try to hit as many as we can before our time's up. The first question is, one person would be sufficient to fulfill the fully operational requirement, correct?
Yes.
As long as they can show their binder to the inspector and help with any requests.
Yes, that is correct. So let's take it a step further. It's not just the policy binder, but looking at all of like the HR and patient records and all of those things that are covered in the standards for your accreditor, as long as one person, and it might be the office manager, because the owner is on vacation, say,
Right.
as long as that individual is able to show us everything, that's fine.
Perfect. And should suppliers still verify licensure directly with the licensing agency, or is the licensure database now 100% up to date at all times?
Well, okay. So I would do both. I would look at the Palmetto Novitas, but then if they, you need to know the nuances. So, say for example, we talked about New York before. I'm not going to talk about New York again. So, say you're in Chicago and you need a license to operate a DME in the state of Illinois, then I would not only check on the database with the Palmetto and so forth, but I would, because you're going to have to apply for it or renew it. A lot of the licenses you're able to renew online. The initial is what takes the most time, I think. But again, each state is different. So it's always necessary to go to the state to see exactly what, because they could have changed something. I mean, there have been states that all of a sudden have come up with some license that isn't even on the Palmetto Novitas. We found that recently, and I'm having a senior moment. I can't remember what that was, but it was something that we had never heard of, and we were verifying, and it's like, where did this come from? And darn if it wasn't something that the state just, oh, okay, now we want this little license. So yes, that was long-winded, but yes, I would check
Well,
with the
that's
state
great.
as well.
We've got a couple questions about posting hours. So I'm going to try to hit a couple of them. But what's the procedure to change your posted hours with Medicare?
Okay, so if you're a current provider, obviously the 855S, you could do it in that or in PCOS, I would think. And then you have to make sure that the AO knows the changed hours and that you're fulfilling the 30 hours a week. Remember that, because that's key as well in terms of the supplier standards.
Super. And then in our business model, they say we do not have any employees or a storefront. We utilize contractors to provide services to patients at facilities. How do we manage this with business hour requirements? The owner is the only responsible party at our registered location, and they are not always in the office during our posted hours.
Okay, so I may ask that person to contact me direct because it's a little convoluted. But
Yep.
if they only do facility business, again, do they have this is about a PTAN, a Medicare number
Mm.
with these requirements. So if they're doing facilities and say they're accredited, but they don't have a Medicare number, or do they have a Medicare number? Because it's all about the requirements of keeping that Medicare number, even if they mainly do facilities. And if you need more of an answer, then, here's
Yeah.
my email.
Yep.
Send me an email on that.
Super. If equipment is unboxed in the warehouse, ready to grab and restock the showroom, but in a patient-ready area, is it required to be bagged/covered?
Okay. So let's talk about why you cover equipment. If it's in a patient-ready area, you want to make sure, like, how long is it in that patient-ready area? So the whole point of covering with a piece of plastic, whether it's a bag or you're just doing a cover in an interim, is to prevent it from getting dirty or whatever, so that when it gets to the patient, it's, you know, sparkling, it's, been cleaned, it's, in good working order, all of those things. So you can have it in a showroom, like many people have it in a showroom, and they have a few things out and they're not they're not bagged. They've been clean, but they're not bagged. But when, okay, all of a sudden they decide, okay, Mrs. McGillicuddy wants that power chair, then they should do a quick cleaning on it and cover it to deliver to Mrs. McGillicuddy.
I like Mrs. McGillicuddy. Can you speak to what vendor agreement would be required between the supplier and a drop ship vendor? This was a communication related to compliance with supplier standards. When we spoke to our vendors, they weren't aware of additional requirements. We have BAAs, but we read that we should have an actual agreement, just not sure what that agreement should contain.
Okay, so typically we see that they have agreements with, but who is, I guess the bigger question is, who is requiring them to have that agreement?
Right.
Is it
Maybe
their
that's a
AO?
question
Is
that
it
they could, yep, put in for more information or email
right,
you directly to
right?
get that answered. That'd be
Because
super.
if it's the AO, it might, if it's us, please let me know. Certainly, a lot of times it's good to have agreements, contracts, whatever, with outside vendors just to protect your business
Mhm.
with who's responsible for what. So, right there, I like the fact that the provider has a BAA. That's, check. You did that good, but I don't have enough information.
Sure. Sure. No, I think that's fair. And how do you report changes to Medicare once you have your accreditation? For example, change your hours or bonds, etc.
Okay, again, I think a lot of the changes are reported through PICOs.
Super. Let's see. How long is the site visit when AO comes to your location?
Okay, so I can only address the compliance team, but our surveys typically, and again, we're talking one location, all right, as opposed to multi locations. One location, typically, we do a 1 day visit, and it's all day.
Thought. Are you open to staff using their resources, aka reference a survey readiness binder, or do you expect staff to be able to memorize it all?
No, we don't expect anybody to memorize. I think it's most important that the staff understand what the actual process is, because that's what they're doing, depending on their job, of course. That's what they're doing day to day. And if there's a question or whatever, that they then would know, oh, I need to check the policy for that.
Mhm.
That's perfectly, acceptable.
I would imagine be a lot to memorize.
Yes, exactly.
So, what happens if corrective action process goes past your accreditation date? Are you still able to bill claims, or do you have to wait until everything gets approved and your accreditation gets renewed?
Okay, that's a tricky question. Um, Again, accreditation is separate from the billing part of it. We can deny or revoke or terminate or whatever with regard to accreditation and then report it. We're not the ones that would remove the PTAN number, so that then, obviously that would impact billing. Now, clearly, you want everything to be done prior to the expiration date. And with all of these added things that are happening because of the final rule and the 100% compliance and the cap and all of that, with this back and forth. That's where, number one, if you're renewing, if whatever your status is, whether you're a new provider or a renewing provider, you want to make sure that you're giving the AO a fair amount of time, at least a couple months. All right. We, when we're talking to people that, well, certainly with multi-site, I'm saying, okay, you should come in the door 6 months, even if you're one location, because understand you've got to put everything together, make sure that on your end that you're comfortable with what your status is. Then you, like with us, you submit what we call an on-site ready report. Okay, I'm ready, anytime. And then, based on our schedule, we then put the provider on the schedule. They obviously have no idea because it's all unannounced.
Right.
And we then show up, and the provider, number one, the provider came to us maybe 2 weeks prior to their expiration date because they left another AO. They came to us. Well, now, guess what? That's really difficult. Now, if the provider is perfect, we get out there, we go, oh, wow, you scored 100%. And now you don't need a cap. You get your letter, bada boom, bada bing, you're good, right? But okay, it only takes one cap to screw that up because we have to send the scoring, we send the cap, they do the cap comes back to us. We then review it. We've got like a three level review on everything to make sure that we're covering our bases. And so anybody that has an expiration date, you want to make sure that whatever AO you're dealing with, that you get, and a lot of it goes back to like renewing with payment. They pay at the last minute. Well, then, okay, now you could be going down a slippery slope with, okay, yes, you'll get done, you'll get seen, but then if you're not 100% compliant, it's gonna take longer. And is it gonna go over the expiration date? It could. So you see, it's a whole new day.
Right. There's a lot of tricky
Yes.
little
Yes.
specifics there. Let's do one more question. I know we've got lots of questions here, and all of these will be supplied to the compliance team to address directly. So don't anyone panic. But here's our last one. Speaking specific to cash sales, can an accredited provider sell a product for cash that is not currently on the PTAN while awaiting survey, but meeting all state and manufacturing requirements, such as custom manual wheelchairs?
Okay, so they have a PTAN, but they want to sell it for cash.
An accredited provider to sell a product for cash that is not currently on the PTAN while awaiting survey.
Oh, sure, of course. That's the whole thing is you don't have your PTAN number, you're gonna sell for cash.
Super. Sandra, thank you so much for being our presenter today. A large thank you to the compliance team and, of course, everyone that joined us. Quick reminder, the session was recorded and a link will be emailed to all registrants. So a lot of folks have been asking about the presentation. Rest assured, you will get an email with that recording. If we didn't get to your question, again, don't worry. The remaining questions will be shared with the compliance team for a direct follow-up. Be sure to visit hmenews.com/webcast for additional upcoming sessions. Thanks again, Sandra, and everyone. Have a great rest of your week.
Thanks so much.
Bye, guys.